Good morning, everyone. I am extremely happy to be a guest today during this FARF educational session. My name is Bertaina. I am an associate professor at School of Medicine at Stanford, and I am a stem cell transplanter for children. I am also the head of the stem cell transplant section within the division of hematology, oncology, and stem cell transplantation. And today I've been asked to talk to you a little bit about alpha beta T cell depleted haploidentical transplant for children and young adults with Fanconi anemia. The reason why I've been asked of talking with you about that is because I am the one who back in 2010 really pioneered this strategy of graft manipulation and then exported this strategy in many other areas worldwide, including this country. So in the next 15-20 minutes, I'm going to explain you the rationale behind this strategy of graft manipulation and also a number of results in patients with Fanconi anemia that I hope can give you the information that you are looking for. Let me start from the reason why we are trying to use alternative donors for children in the need of a transplant. Well, the rationale of that really lies in the need of identifying potential donors for those who lack fully matched donor. In fact, only 25% of our patients can identify a full matched sibling donor in the family. And despite the presence of over 31 million of unrelated donors worldwide, along with over 700,000 units of cord blood stored in the banks, there is still a huge proportion of patients who cannot allocate a suitable donor in a suitable frame time. This number is around 40%. For patients of Caucasian origin, but this number can increase up to 75% for some ethnic minorities. Thus, really the need of developing new strategies that can allow us to use alternative donors without the risk that historically were related to those. And that's why the haploidentical transplant really is considered the new black. This is an editorial that Mike Pulsifer wrote when I published my first paper back in 2014, really describing how the alpha beta T cell depletion as graft manipulation strategy changed the field. This is not the only strategy of graft manipulation available, and these figures summarize the burst or explosion of really scientific translational discoveries that try to minimize the risk of graft versus host disease when we use a donor which is fully mismatched for an entire haplotype, while maintaining a protection towards the infection and also a protection towards leukemia when we are transplanting children with cancer cells. In this way, really the use of haploidentical donors, mostly one of the two parents, but sometimes also a sibling, makes a graft virtually available for every patient in the need of a transplant. And if we think about the evolution of the strategy of T cell depletion, this slide shows you how we moved from a strategy of positive selection to a strategy of negative depletion. Oops, sorry. I'm not going to move my mouse so I can show you. So on the left part of the figure, you can see that back in the 1990s, we were using a positive selection strategy, where from the graft of a donor, we were selecting only the stem cell, which were characterized by the presence of the marker CD34. With this strategy, really, we were able to achieve a very high rate of engraftment with extremely low risk of acute and chronic graft versus host disease. But unfortunately, the number of life-threatening infections was extremely high. So that's why in 2010, we decided to move from a positive selection strategy to a negative depletion approach. And here the goal was to remove from the graft only the cells really carrying the alpha-beta chain of the TCR receptor, which are the only T cells responsible of mediating graft versus host disease. In this way, in the graft, we don't have only the stem cell, the purified stem cell, the CD34 positive cells, but we also have a number of other effector cells, such as NK cells and gamma delta T cells, which are promptly available with the graft to fight infection and protect toward leukemia recurrence. And the following slide can explain even better what I'm talking about. So this is what happened when we were doing the CD34 positive selection. Here, the concept is that we take one of the two parents, the mother or the father, which is 50% matched with the recipient. We select from peripheral blood stem cells only CD34 positive cells. So we eliminate completely all the T cells from the graft. What are the advantages of this procedure? Well, that is virtually applicable in any cases, and that responds to the need of an urgent transplant. However, the complete physical elimination of the T cells really is responsible of this delayed immune recovery and therefore of a risk of viral infection, fungal infection, and can also play a role in a risk of graft failure. So that's why we decided to move, as I mentioned, from a positive selection strategy to a negative depletion one. And again, to help you understand all the rationale behind, I created this little animation. When we infuse a CD34 into a patient, the only lymphocyte that we have and we can count on are NK cells from the donor. However, these NK cells are very immature and they require up to 6 weeks to express on their surface some activator and inhibitor receptor that really characterize the mature form of the NK cells and can be functional active. As activated in this way, the NK cells can be able to reduce the graft rejection, are not creating graft versus host disease, and can help in preventing leukemia relapse. However, there is this gap, this temporal gap of at least 6 weeks, where our patients are completely exposed to an infection. And so they can be really at risk of life-threatening infection. So that's why my idea of using alpha-beta T cell depletion. Because in this way, we have not only the stem cell, but also the gamma delta T cells and NK cells, which are already mature because they are not originating from the stem cell, are stem cells which are adoptively transfused with the graft. And so they don't need this 4-6 week of maturation phase. They already are mature. In this way, these cells, at the moment that we infuse the graft, are promptly available and they can help in controlling infections and controlling leukemia. So using this approach, we first transplanted 23 children with a variety of non-malignant disorders. This was back in 2014. And we showed that with this strategy, we were able to cure 90% of children with these diseases, with a transplant-related mortality, which was lower than 10%. This was revolutionary because it was the first time that using a T-cell depleted haploidentical transplant, we were able to achieve such results. And in this first report that I published in 2014, there were already 4 Fanconi anemia patients which had a wonderful outcome after the transplant, no rejection, no graft versus host disease, all patients alive and disease-free. Here I show you a figure with an update unpublished of this cohort. Actually, this number that you can see now, 33, went up to 54, and the results remain absolutely comparable. The overall survival is above 90%, and the transplant-related mortality is even lower and about 5%. But of course, your interest is about Fanconi anemia patients. So let me really go into details about what happened and what is my experience with Fanconi anemia patients. Here you can see 2 different data. The first one are coming from a publication that we have done at the ASH meeting in 2016. At that time, we presented 10 patients with Fanconi anemia receiving alpha-beta T-cell depleted haploidentical transplant. You can see that remarkably, no patient died for transplant-related complication. Only one patient experienced a graft failure, so the event-free survival for this cohort was 90%. And remarkably, no patients experienced either acute or chronic graft-versus-host disease. Below, you can see some preliminary data of a trial that we opened in 2014 and we closed in 2017, but the data are not yet published. This was an interim analysis about 8 patients with Fanconi anemia. Here, the backbone of the transplant was exactly the same, alpha-beta T-cell depleted haploidentical transplantation, with the infusion post-transplant of T-cells derived from the donor, which at that time were genetically modified with a suicide gene able to control GVHD in case of occurrence. Data on these patients are outstanding. All patients are alive and disease-free without sign of graft-versus-host disease. In this little plot on the right, you can see the recovery of the neutrophil and the platelet. As you know, being parents of children with Fanconi anemia, one of the most problematic features are really represented by the neutropenia and therefore the risk of infection, and the thrombocytopenia with the risk of bleeding. Here you can see that 20 days after the transplant, these patients have over 3,000 neutrophil and over 300,000 platelet, exactly because the time of the engraftment and therefore of the recovery is extremely fast and very robust. But I'm very happy that this presentation comes timely with the publication of our last report. These are data that I produced in Italy, so not in US, as I had the opportunity to comment with some of these families. All the data so far published on alpha-beta T-cell depleted haplotransplant are coming from Italy, from Europe. And those data are data that we produce in the center that I was leading before in Roma, the Bambino Gesù Children's Hospital. But this is a paper which summarized the outcome of 24 patients with Fanconi anemia. In this case, the median age at the diagnosis was 6.2 years, and the median age at the transplant was 8 plus 6 years. 8.6 years. The oldest patients in this case were 20.7 years old, just to give you an idea of the frame time. Well, first of all, in this slide, you can see as a main message is that no one of these patients died due to transplant-related complication. This is amazing if we consider that we are doing this transplant in children with Fanconi anemia that so had a previously infection and other complication. 2 patients experienced the primary graft failure, and therefore the event-free survival is 86.3% for this cohort. The 2 patients who experienced primary graft failure underwent a subsequent successful transplant using as a donor the other parent. I also would like to comment in this case the median time for neutrophil engraftment, which was 11 days, and for platelet recovery, which was 10 days. That means that 10 days after the transplant, these patients are transfusion independent. And actually our median time for discharge after this transplant is between 20 and 25 days, exactly in light of this very fast recovery. But graft-versus-host disease is a hallmark of the transplant for Fanconi anemia. We all know that we want to avoid either acute or chronic graft-versus-host disease in these patients because it can predispose to the development of cancer. Well, the good news is that the incidence of graft-versus-host disease with this approach is extremely low. Here you can see that the cumulative incidence of grade 1 to 2 acute GVHD for this cohort of patients was 17%. That means that no patient developed grade 3 or 4 acute GVHD. And all these grade 1 and 2 can be resolved with either topical steroids or low-dose systemic steroids. Even more remarkably, only one patient out of these 27 experienced limited skin-only chronic graft-versus-host disease, with a total cumulative incidence of 5.5%. I really wanted to highlight again these numbers. One of the questions that I always often received from you as a parents is, should we use a 10 out of 10 unrelated donor instead of one of the two parents? And my answer for who talked to me is always no. That's why the risk of complication, especially graft versus host disease, with this alpha beta depletion is so minimal that, in my opinion, there is no advantage in using an unrelated donor. However, there are many advantages in using an haploidentical donor. When we stimulate, mobilize, and collect a father or a mother, that occurs in our center under our watch. So we can decide how many cells collect, how many cell process, if 2 collections are required, if 1 is enough. Whenever we ask for an unrelated donor, although we ask a target of cells that we know being the best possible for the patient, not always this is possible for different reasons, and we don't have a full control. So unless no parent is available or eligible for being a donor, my choice and my recommendation would be always to use one of the parents, because I think that in this case, the graft composition might be much more appropriate, while the risk of graft versus host disease is definitely not higher than using a 10 out of 10 or a 9 out of 10 unrelated donor. I told you that all these data have been produced in Europe, and specifically in this case in Italy. I just want to show you a little bit of what we have done at Stanford so far. Since I joined Stanford, which was September 2017, we have transplanted with an alpha beta T cell depleted approach 60 patients. 60 patients that receive a transplant from either a mother or a father or a haploidentical sibling. And here you can see the breakdown between malignant and non-malignant disorders. In this case, 45 patients had an acute leukemia, while 12 had a non-malignant disorder. And between the patients with non-malignant disorder, 2 patients had Fanconi anemia. Remarkably, while one of these 2 patients is a young child, the other one was a 23 years old young adult with a lot of complications who render her not eligible for receiving a transplant in other center and before. Both patients went extremely well and grafted, didn't experience GVHD, didn't experience main infection, and are now back home doing almost a normal life. The conditioning regimen I am using, I know that this is another important topic for the families, and we can discuss more during the Q&A, use low doses of fludarabine and cyclophosphamide with 1 single fraction of TBI 200 centigrade. I know that radiation always are seen like evil in the Fanconi community, and I totally understand why. However, we have proven with many studies that this single fraction is not compromising the risk of secondary malignancies more than the use of chemotherapy, while actually the presence of the single fraction really is crucial for the engraftment. And so I always recommend to use this conditioning regimen, which otherwise is extremely well tolerated. We didn't have any single case of liver veno-occlusive disease or other toxicity using this approach. As discussed before, the neutrophil and platelet engraftment is extremely rapid with this approach, 12 days for the neutrophils, 15 days for the platelet. the incidence of graft versus host disease remain remarkably low. This is for the overall cohort, so pulling together leukemia and non-malignant disorders. 23% the grade 2 to 4 acute GVHD, with only 7% of grade 3 to 4. But if we look at the non-malignant disorders, the incidence of GVHD is much lower, is only 9%, and patients in this case had only grade 1 or 2. No one in the non-malignant setting had grade 3 or higher graft versus host disease. And also in terms of chronic graft versus host disease, only 2 patients out of the 60 developed limited skin-only graft versus host disease, with the cumulative incidence being lower than 5%. And here is just a slide to conclude about the Stanford Comprehensive Bone Marrow Failure Syndrome Program. I know you have a lot of conversation with Dr. Chekhovitz in our institution, who is really taking care of the relationship with the Fanconi community, considering her outstanding interest in this disease. Here there is the link to the website that we actually just renewing with all the pipeline of new clinical trials that we are opening. Today, really, my goal is to talk to you about alpha-beta depletion. So I'm not going to mention other trials, but I'm happy to answer any question if you have during the Q&A. I encourage you in visiting the website, contacted either me or Dr. Chekhovitz by email. If you have a question. Here the message is that not only we have an expertise in stem cell transplant for Fanconi anemia, but we also have a very big multidisciplinary team that can take care of these patients, like you know better than everybody else those patients need. I hope really that with these slides I clarified some of the point about the alpha-beta T-cell depletion, but I'm really looking forward to a discussion with you and to answer any question that can help in deciding what's the best treatment for your son or your daughter. Thank you so much.